Hey guys, welcome to another episode of the Human AI podcast. Today we're going to talk about kidney function and the kidneys in general, the urinary tract. We're going to talk a bit about the posterior abdominal wall and about urine formation. I'm here with Grog, who's going to help us understand these topics. I'm just a student. I'm just going to ask some questions and hopefully AI can provide us with some valuable information. Take everything Grog says with a pinch of salt and make sure to cross-reference everything you listen to. Having said that, I hope you find this information enjoyable and valuable. Grog, could we start with kidney, and so kidney function, renal function, let's start from there.
All right, let's dive into kidney function, or renal function, for your podcast listeners. The kidneys are powerhouse organs, filtering blood to remove waste, regulate electrolytes, and maintain fluid balance. They produce urine, control blood pressure through the renin-angiotensin system, and even help with red blood cell production via erythropoietin. Each kidney has about 1 million nephrons, the tiny units where filtration and reabsorption happen. Want me to break down the nephron's role in urine formation, or zoom in on something specific?
Well, explain us excretion, elimination.
Cool. Let's talk excretion and elimination in the context of the kidneys. Excretion is the process where the kidneys filter out waste products like urea, creatinine, and excess electrolytes from the blood to form urine. This happens in the nephrons through filtration at the glomerulus, reabsorption, and secretion. Elimination is the final step of urine. Containing these wastes leaves the kidneys via the ureters, collects in the bladder, and exits the body through the urethra. It's a slick system to keep your body free of toxins and balanced. Want to dig into the specifics of how the nephron filters, or something about the urinary tract's role?
So, what's the difference with elimination and excretion? What's the difference?
Great question to clarify for the podcast crew. Excretion is the kidney's job of filtering waste from the blood and forming urine. Think of it as the process of collecting and preparing the trash, like urea and excess salts in the nephrons. Elimination is the final act of getting that urine, now full of waste, out of the body through the ureters, bladder, and urethra. So, excretion is making the urine, and elimination is kicking it out. Want me to dive deeper into any part of that process?
When does renal function break? When do we start having problems? Talk to us about uremia or azotemia, drug toxicity.
All right, let's get into when renal function goes haywire and terms like uremia and azotemia come up. Renal function starts breaking down when the kidneys can't filter waste properly, often due to conditions like chronic kidney disease, acute kidney injury, or severe dehydration. This leads to a buildup of waste in the blood, which brings us to azotemia and uremia. Azotemia is when nitrogenous wastes, like urea and creatinine, pile up in the blood because the kidneys aren't clearing them out. It's a lab finding, often an early sign of kidney dysfunction, and can be caused by reduced blood flow to the kidneys, obstruction, or direct kidney damage. Uremia is the next level, a clinical syndrome where that waste buildup causes symptoms like fatigue, nausea, confusion, or even heart issues. It's basically the body getting toxic from all that unfiltered junk, often seen in advanced kidney failure. Rock toxicity might be your colorful way of saying the toxic effects of this waste overload, right? The kidneys failing to excrete these compounds messes with your body's balance, leading to serious complications if untreated. Want me to focus on what causes these conditions, or maybe treatments like dialysis?
I want to ask you about the organization of the kidney. So you have the cortex, the outer, and you have medulla, pyramids, draining into the pelvis, which drains into ureters.
Nice. Let's break down the kidney's organization for the podcast listeners. The kidney has a layered structure, starting with the outer cortex, where most of the nephron's filtering units, the glomeruli, are located. This is where blood filtration kicks off. Deeper inside is the medulla, organized into cone-shaped pyramids, which contain the loops of Henle and collecting ducts that concentrate urine. These pyramids have their tips, or papillae, pointing toward the center of the kidney, draining urine into minor calyces, which merge into major calyces, and finally into the renal pelvis. The renal pelvis acts like a funnel, channeling urine into the ureter for elimination. It's a super efficient setup for filtering, concentrating, and moving urine out. Want me to zoom in on how the cortex and medulla work together, or something specific about the nephrons in there?
Well, I would like to ask you about the cortical and juxtamedullary nephrons. What's the difference?
Great topic for the podcast crowd. Cortical nephrons and juxtamedullary nephrons are the two main types of nephrons in the kidney, and their differences come down to location and function. Cortical nephrons, making up about 85% of nephrons, are mostly in the kidney's outer cortex, with short loops of Henle that dip just a bit into the medulla. They're primarily focused on filtering blood and reabsorbing nutrients, handling the bulk of basic filtration. Juxtamedullary nephrons, on the other hand, sit closer to the cortex-medulla border, with long loops of Henle that plunge deep into the medulla. These are key for concentrating urine, allowing the kidney to conserve water and regulate urine osmolarity, especially when you're dehydrated. Their longer loops create a strong concentration gradient in the medulla, critical for water reabsorption. So, cortical nephrons are the workhorses for filtration, while juxtamedullary ones are the specialists for water conservation. Want me to explain the loop of Henle's role in this or something else?
Well, I would like to.
So anyway, we were just talking about
I
cortical...
would like to understand the blood supply a bit. And I want to understand. Also, we have peritubular capillaries and vasa recta. What are these?
All right, let's dive into the kidney's blood supply and those key structures for the podcast listeners. The kidneys get blood via the renal artery, which branches into segmental arteries, then interlobar arteries that travel between the medullary pyramids. These feed into arcuate arteries at the cortex-medulla junction, which send off interlobular arteries into the cortex. From there, afferent arterioles supply the glomerulus, where filtration happens, and efferent arterioles carry blood away. Now, about those capillaries. Peritubular capillaries surround the cortical nephron's tubules, handling reabsorption of water and solutes like sodium back into the blood after filtration. Vasa recta, on the other hand, are long, hairpin-shaped capillaries that follow the loops of Henle and juxtamedullary nephrons deep into the medulla. They're crucial for maintaining the medulla's concentration gradient, which helps concentrate urine by reabsorbing water and solutes without disrupting the osmolarity balance. So, peritubular capillaries are for reabsorption in the cortex, while vasa recta support the medulla's urine concentrating magic. Want me to clarify the blood flow path or zoom in on how these capillaries interact with the nephron?
Why don't we talk a bit about the nerve supply too?
All right, let's cover the nerve supply to the kidneys for your podcast audience. The kidneys are innervated by the renal plexus, a network of autonomic nerves primarily from the sympathetic nervous system, with some input from the vagus nerve for parasympathetic vibes. Sympathetic nerves, coming from the thoracic splanchnic nerves around T10, T12, regulate blood flow by constricting or dilating renal arterioles, which affects filtration rate. They also influence renin release, tying into blood pressure control. These nerves mostly target the blood vessels and juxtaglomerular cells rather than the tubules directly. Parasympathetic input is less dominant, but can modulate minor functions like ureter motility. The innervation is more about fine-tuning blood flow and pressure than directly controlling filtration or urine production. Want me to tie
So
this
what
back?
does the sympathetic do?
The sympathetic nervous system plays a key role in the kidneys, and here's the breakdown for your podcast listeners. Sympathetic nerves, originating from the thoracic splanchnic nerves around T10, T12, innervate the renal blood vessels and juxtaglomerular cells. When activated, they cause vasoconstriction of the efferent and efferent arterioles, which reduces blood flow to the glomerulus and lowers the glomerular filtration rate, basically dialing down urine production
So
during
the
stress.
sympathetic one lowers the GFR.
Exactly. For your podcast crew, yes. The sympathetic nervous system lowers the glomerular filtration rate, or GFR. When it kicks in, it causes vasoconstriction of the efferent and efferent arterioles in the nephrons, reducing blood flow
So
to
we
the
can
glomerulus.
use it at other points. Okay, that makes sense. Let's talk a bit about secretion and reabsorption. So secretion is basically whatever isn't filtered is basically going in a different way. Where though?
All right, let's clarify secretion and reabsorption for the podcast listeners, focusing on your question about secretion. Reabsorption happens mostly in the proximal tubule, loop of Henle, distal tubule, and collecting duct, where useful stuff like water, glucose, and sodium is taken back into the blood from the filtrate. Secretion, on the other hand, is the active process of adding substances from the blood into the filtrate to get rid of them. It's not just what isn't filtered, but specific compounds the body needs to excrete, like drugs, toxins, or excess ions like potassium and hydrogen. Secretion primarily happens in the proximal tubule and distal tubule. In the proximal tubule, organic acids, drugs like penicillin, and waste products are pumped into the filtrate via transport proteins. In the distal tubule, potassium and hydrogen ions are secreted to regulate blood pH and electrolyte balance. This happens around the peritubular capillaries, where blood and tubule are in close contact, allowing transporters to move stuff into the filtrate.
So yeah, I'm just gonna remind you, in this podcast we keep things back and forth quite short. Just make sure you use an effective and efficient use your words effectively and efficiently, dude, and get your point across with the least amount of words as possible.
Got it. I'll keep it tight and efficient. Anything specific about secretion or reabsorption you want me to hit next?
Well, explain to me the differences.
Reabsorption pulls useful stuff like water, glucose, and sodium from the filtrate back into the blood, mainly in the proximal tubule, loop of Henle, and distal tubule. Secretion actively moves waste, drugs, and excess ions like potassium from the blood into the filtrate, mostly in the proximal and distal tubules. Reabsorption saves what you need. Secretion ditches what you don't. Want specifics on where or how?
So secretion goes back. So everything that's secreted is going to get peed, right?
Yup, exactly. Everything secreted into the filtrate, stuff like excess potassium, hydrogen ions, or drugs, ends up in the urine and gets peed out, unless something else messes with the process downstream.
It gets peed, huh? Okay, let's continue. So transcellular and paracellular transport. I want to understand the difference.
All right, for the podcast listeners, let's break down transcellular versus paracellular transport. Transcellular transport is when substances move through the cells of the tubule wall, crossing both the apical and basolateral membranes via channels, pumps, or carriers. Think glucose or sodium being actively reabsorbed in the proximal tubule. Paracellular transport happens between the cells, slipping through tight junctions driven by concentration or electrical gradients, like some water or ions in the proximal tubule. Transcellular is through the cell, paracellular is between cells. Want me to zoom in on examples or mechanisms?
One is between cells and the other is what?
Transcellular transport moves substances through the tubule cells, crossing their membranes. Paracellular transport goes between the cells via tight junctions. Want an example of either?
No, that's okay. Okay. And we've talked in many episodes about glomerular filtration. Why don't we talk a bit about tubular reabsorption then? And let's talk about the sodium-potassium ATPase transporter too.
Cool. Let's hit tubular reabsorption and the sodium-potassium ATPase for the podcast. Tubular reabsorption is the process where the kidneys take back water, glucose, sodium, and other essentials from the filtrate into the blood, mostly in the proximal tubule, loop of Henle, and distal tubule. About 99% of filtered water and sodium gets reabsorbed to maintain body balance. The sodium-potassium ATPase pump, found on the basolateral membrane of tubule cells, is a key player. It pumps 3 sodium ions out of the cell into the blood and 2 potassium ions into the cell, using ATP for energy. This creates a low sodium gradient inside the cell, driving sodium reabsorption from the filtrate through apical channels or co-transporters, often pulling glucose or amino acids along. It's critical for reabsorbing most sodium and setting up other transport processes. Want me to focus on a specific tubule segment or another transporter?
So this is sodium going in or out?
The sodium-potassium ATPase pump moves sodium out of the tubule cell into the blood, while pulling potassium into the cell. This sets up a gradient so sodium can enter the cell from the filtrate, getting reabsorbed. Want me to clarify the gradient's role?
So potassium goes into the urine and sodium out.
Not quite. The sodium-potassium ATPase pump moves sodium out of the tubule cell into the blood, reabsorbing it from the filtrate. Potassium is pumped into the cell, not the urine, but some potassium can be secreted into the urine later,
Okay.
mainly in the distal
Let's talk about tubular secretion to understand. Well, we've kind of talked, but I just want to understand the pumps a bit more.
All right, let's focus on tubular secretion and the pumps involved for the podcast. Tubular secretion moves waste, excess ions like potassium and hydrogen, and drugs from the blood into the filtrate, mainly in the proximal and distal tubules, for excretion in urine. In the proximal tubule, organic anion and cation transporters use secondary active transport, driven by the sodium gradient from the sodium-potassium ATPase, to secrete stuff like creatinine or penicillin. In the distal tubule, potassium-hydrogen pumps actively secrete potassium or hydrogen ions to regulate blood pH and electrolyte balance.
So, what's going on with heat, high heat, and kidney function? Extreme heat.
Extreme heat stresses kidney function big time. It causes dehydration, reducing blood volume and flow to the kidneys, which lowers glomerular filtration rate and can lead to acute kidney injury. Heat also triggers sweating, concentrating blood and raising electrolyte imbalances, forcing the kidneys to work harder to maintain balance. Prolonged exposure can contribute to chronic kidney disease, especially in folks already at risk. Staying hydrated is key to ease the strain. Want me to dive into heat-related kidney damage mechanisms or prevention tips?
No, that's good. Let's jump to our next topic then. Maybe a bit more about the kidneys. And let's also talk about the urinary tract. So urinary tract has the kidneys. It also has the ureter, the urinary bladder, and the urethra.
All right, let's wrap up kidneys and shift to the urinary tract for the podcast. The kidneys filter blood, form urine, and regulate fluid and electrolytes, as we've covered with nephrons, reabsorption, and secretion. The urinary tract then handles urine's journey out: ureters, urinary bladder, and urethra. Ureters are muscular tubes that carry urine from the renal pelvis to the bladder via peristaltic contractions. The bladder, a hollow muscle organ, stores urine up to about 500 millimeters until you're ready to void. The urethra channels urine out, with internal and external sphincters controlling flow. It's short in females, longer in males. The tract's job is transport, storage, and elimination, all while preventing leaks or infections. Want me to focus on ureter function,
What
bladder
are
control?
peritoneal pouches?
Peritoneal pouches, or peritoneal recesses, are spaces within the peritoneal cavity formed by folds of peritoneum, the membrane lining the abdominal cavity. In the context of the urinary tract for your podcast, you're likely referring to areas near the kidneys or ureters, like the pararenal or perirenal spaces, though they're not classic pouches. True peritoneal pouches, like the vesicuterine pouch between bladder and uterus in females, or rectourine pouch of Douglas, are more relevant to pelvic organs.
Yeah, tell me about the pouch of Douglas, for instance.
The pouch of Douglas, or rectourine pouch, is a peritoneal recess in females, located between the rectum and the uterus. It's the lowest point in the pelvic peritoneal cavity when standing, so fluid, blood, or pus can collect there, potentially causing issues like abscesses or signaling conditions like endometriosis. For the podcast, it's relevant to the urinary tract indirectly, as it's near the bladder and can affect nearby structures if inflamed or infected. Want me to explain its clinical significance or tie it back to urinary tract anatomy?
So good, so good. Why don't we talk a bit about the renal capsule, the perinephric fat, and the renal fascia?
All right, let's dive into the renal capsule, perinephric fat, and renal fascia for the podcast. The renal capsule is a tough, fibrous layer directly covering the kidney, protecting it and maintaining its shape. Surrounding that is the perinephric fat, a layer of adipose tissue that cushions the kidney and anchors it within the abdominal cavity. Outside the perinephric fat is the renal fascia, a thin connective tissue sheath that encloses the kidney, perinephric fat, and adrenal gland, securing them to the posterior abdominal wall while allowing some movement. These layers protect, insulate, and stabilize the kidneys. Want me to connect this to kidney function or nearby structures like the ureters?
So, what are these structures that I mentioned? What do they do?
The renal capsule, perinephric fat, and renal fascia each have distinct roles. The renal capsule is a fibrous sheath around the kidney, shielding it from trauma and infection while holding its shape. Perinephric fat surrounds the capsule, acting as a protective cushion and insulator, also helping anchor the kidney. Renal fascia is a tough connective layer encasing the kidney, fat, and adrenal gland, stabilizing them to the abdominal wall while allowing slight mobility. Together, they protect and position the kidneys for optimal function. Want specifics on their clinical relevance?
I want to ask you about nephroptosis. When does it happen?
Nephroptosis, or floating kidney, happens when a kidney drops more than normal, usually over 5 centimeters, when you stand up, due to weak support from the renal fascia, perinephric fat, or surrounding structures. It's often linked to low body fat, rapid weight loss, or connective tissue disorders, and is more common in thin women. Symptoms can include pain, nausea, or urinary issues, but many cases are asymptomatic. For the podcast, it's a rare condition, sometimes found incidentally. Want me to cover diagnosis or treatment options?
No, it's okay. So, we've talked. So we have a fibrous capsule, and then we have the renal cortex, and then we have the pyramids in between the renal columns. What about the renal papilla, the major calyx, and the minor calyx? What are those?
All right, let's clarify these kidney structures for the podcast. The renal papilla is the tip of each medullary pyramid, where urine drips from the collecting ducts into the minor calyx. Minor calyx are small, cup-like structures that collect urine from each papilla. Several merge to form major calyx, larger funnels that channel urine into the renal pelvis, then the ureter. The renal columns, by the way, are cortical tissue extensions between pyramids, supporting blood vessels. So, the pillae release urine, minor and major calyxes collect and direct it. Want me to link this to urine flow or something else?
I'm a bit confused. What are these?
No worries. Let's simplify for the podcast. The renal papilla is the pointy end of a medullary pyramid where urine exits into the minor calyx. Minor calyces are small cups catching urine from each papilla. Several minor calyces join to form a major calyx, a bigger funnel directing urine to the renal pelvis and then the ureter. They're all part of the kidney's drainage system. Clearer now? Want me to repeat or dive deep?
That's better, that's good. And what's the renal sinus?
The renal sinus is a cavity within the kidney, located near its center, where the renal artery, vein, nerves, and renal pelvis hang out. It's surrounded by the medulla and contains fat and connective tissue, acting like a hub for the kidney's blood vessels and urine collection system, leading to the ureter. For the podcast, think of it as the kidney's inner logistical core. Want me to tie it to the calyxes or blood supply?
Tell me one more time about what this is, I don't get it.
All right, super simple for the podcast. The renal sinus is a hollow space inside the kidney. It's where the renal artery, vein, nerves, and the renal pelvis, which collects urine from the calyces, all sit, cushioned by fat. It's like the kidney's central hub for blood and urine pathways. Got it? Want me to connect it to something specific?
Okay. Let's talk a bit about kidney development now and how it grows. And let's talk a bit about ectopic kidney too and hydronephrosis.
All right, let's cover kidney development, ectopic kidneys, and hydronephrosis for the podcast, keeping it concise. Kidney development starts in the embryo with 3 stages: pronephros, mesonephros, and metanephros. The metanephros, forming around week 5, becomes the permanent kidney, with the ureteric bud shaping the collecting system and nephrons forming by week 12. Kidneys climb from the pelvis to the upper abdomen by birth, guided by blood vessel changes. An ectopic kidney is when one or both kidneys end up in the wrong spot, like the pelvis, due to failed migration during development. It's usually asymptomatic, but can cause urine flow issues or infections. Hydronephrosis is kidney swelling from urine backup, often due to blockages like kidney stones, tumors, or congenital ureter issues. It stretches the renal pelvis and calyces, potentially damaging nephrons if severe. Want me to focus on ectopic kidney complications or hydronephrosis causes?
Oh, it's okay. But I do want to talk a bit about congenital anomalies of the kidney and talk a bit about suprarenal glands too.
All right, let's dive into congenital anomalies of the kidney and the suprarenal glands for the podcast, keeping it tight. Congenital kidney anomalies include issues like horseshoe kidney, where the kidneys fuse at the lower poles, often causing no symptoms but raising risks for infections or stones. Renal agenesis, missing one or both kidneys, or hypoplasia, underdeveloped kidneys, can lead to kidney failure if bilateral. Ectopic kidneys, as mentioned, sit in abnormal spots like the pelvis. Polycystic kidney disease, a genetic condition, forms fluid-filled cysts that impair function over time. Most anomalies arise from disruptions in embryonic kidney migration or development. Suprarenal glands, aka adrenal glands, sit atop each kidney, enclosed in renal fascia. They've got 2 parts: the cortex, producing hormones like cortisol, stress response, and aldosterone, blood pressure regulation, and the medulla, releasing adrenaline and noradrenaline for fight or flight. Congenital adrenal hyperplasia, a common anomaly, messes with hormone productions, often causing salt imbalances or early puberty. Adrenal issues can indirectly affect kidney function via blood pressure changes. Want me to zoom in on a specific anomaly or the adrenal's hormone-kidney connection?
Well, so I want to talk about the suprarenal glands. Why are they endocrine glands? What's this yellow cortex? And what's this brown medulla?
The suprarenal glands, or adrenal glands, have a distinct look due to their structure, perfect for the podcast. They appear yellowish overall because of the lipid-rich adrenal cortex, which makes up the outer layer. The cortex is yellow due to cholesterol and fat stored in its cells, which produce hormones like cortisol for stress and metabolism, and aldosterone for blood pressure and sodium balance. The inner medulla, brownish due to its dense blood vessels and chromaffin cells, produces catecholamines like adrenaline and noradrenaline, driving the fight or flight response. The color contrast comes from the cortex's fatty content versus the medulla's vascular, pigmented cells. Want me to explain how these hormones impact the kidneys or dive into adrenal disorders?
Yeah, let's do it.
All right, let's connect the suprarenal gland's hormones to kidney function for the podcast. The adrenal cortex's aldosterone regulates blood pressure and electrolyte balance by acting on the kidney's distal tubules and collecting ducts. It promotes sodium reabsorption, which pulls water back into the blood, raising blood volume and pressure while excreting potassium. Cortisol, also from the cortex, helps manage stress, but can indirectly affect kidneys by altering blood flow and glucose levels. The medulla's adrenaline and noradrenaline ramp up heart rate and constrict blood vessels, including renal arteries, reducing kidney blood flow during stress to prioritize other organs. This can lower glomerular filtration rate, short term. Disorders like adrenal hyperplasia can overproduce aldosterone, causing high blood pressure and kidney strain, while adrenal insufficiency can lead to low blood pressure and electrolyte chaos. Want me to focus on a specific disorder or how kidneys handle these hormone signals?
I thought that endocrine meant that we go in the blood, and exocrine meant that we actually go out of a duct. So what does an endocrine gland mean?
Great question to clear up for the podcast listeners. An endocrine gland, like the suprarenal adrenal glands, releases hormones directly into the bloodstream, no ducts involved. These hormones, like cortisol or adrenaline, travel through the blood to target organs, such as the kidneys, to regulate functions like blood pressure or metabolism. Exocrine glands, on the other hand, secrete products like sweat or digestive enzymes through ducts to specific surfaces or cavities. So, endocrine means internal hormone delivery via blood. Exocrine means external secretion via ducts. Want me to tie this back to how adrenal hormones affect the kidneys specifically?
I don't get it. Tell me again. And then when you do, let's start talking a bit about the ureter.
All right, simple breakdown for the podcast. Endocrine glands, like the adrenal glands, release hormones like cortisol or adrenaline straight into the blood, no ducts, to act on distant organs like the kidneys. Exocrine glands use ducts to send stuff like sweat or saliva outside, or to specific spots. Now, onto the ureter. It's a muscular tube about 25-30 centimeters long, carrying urine from the kidney's renal pelvis to the bladder. Peristaltic waves push urine along, and its layered wall mucosa, muscle, and fibrous tissue prevents leaks and blocks. Ureters sit retroperitoneally, entering the bladder at an angle to stop urine backflow. Want me to cover ureter
So
issues
how do
like...
we have endocrine gland though? I'm still confused.
No worries. Let's clear it up for the podcast. Endocrine glands, like the adrenal glands, are specialized organs that make hormones and release them directly into the bloodstream without any ducts. Think of them as chemical messengers sent through the blood to control things like kidney function, blood pressure, or stress response.
Okay.
For example, the adrenal gland's cortisol.
Okay. So the ureter, it crosses
Got
to the anterior to the genitofemoral nerve, and then okay. Let's talk a bit about the course of the ureter in the pelvis.
All right, let's focus on the ureter's course in the pelvis for the podcast. The ureter enters the pelvis by crossing over the common iliac artery, just above where it splits into internal and external iliacs, roughly at the pelvic brim. It runs retroperitoneally along the lateral pelvic wall, anterior to the internal iliac artery and vein. In females, it passes close to the uterine artery, water under the bridge, and near the cervix. In males, It's near the vas deferens. As it approaches the bladder, the ureter runs medially, entering the bladder wall at an oblique angle to form the ureter-vesical junction, which prevents urine backflow. It's not directly anterior to the genitofemoral nerve. That nerve's more lateral, near the psoas muscle, but the ureter can be close to other pelvic nerves like the obturator. Want me to detail potential obstruction points?
This course is a bit weird, so it goes downward in front of the internal iliac artery to reach the ischial spine and then turns forward and medially to enter the upper lateral angle of the urinary bladder. Okay. What about vas deferens? How does it relate to that?
All right, let's clarify the ureter's pelvic course and its relation to the vas deferens for the podcast, keeping it clear. The ureter descends into the pelvis, crossing the common iliac artery, then runs downward along the pelvic wall, anterior to the internal iliac artery and vein. It doesn't quite hit the ischial spine, but curves forward and medially near it, heading to the bladder's upper lateral angle at the ureter-vesical junction. In males, the vas deferens, the tube carrying sperm from the testes, crosses over the ureter as it heads toward the prostate, creating a key anatomical relationship, water under the bridge, like with the uterine artery in females. This crossing happens just before the ureter enters the bladder. The vas deferens doesn't affect ureter function, but is a surgical landmark. Want me to explain surgical relevance or revisit the ureter's path?
No, that's so good. Let's talk though about ureteric constrictions. We have the ureteropelvic junction, the crossing of the common iliac artery, and the site of entrance to the bladder.
Perfect. Let's hit ureter constrictions for the podcast. The ureter has 3 natural narrowing points where stones or blockages are more likely. The ureter-pelvic junction, where the renal pelvis funnels into the ureter. The point where the ureter crosses the common iliac artery at the pelvic brim, compressing slightly. And the ureter-vesical junction, where the ureter enters the bladder at an oblique angle, creating a tight passage. These spots are prone to obstruction, causing issues like hydronephrosis. Want me to dive into obstruction consequences or related anatomy?
Sure. Well, I want to understand this a bit more, to be honest.
No problem. Let's break down those ureter constrictions again for the podcast, keeping it clear. The ureter has 3 spots where it naturally narrows, making it easier for stones or blockages to get stuck. First, the ureter-pelvic junction, where the renal pelvis transitions into the ureter, tight because it's a funnel point. Second, where the ureter crosses over the common iliac artery at the pelvic brim. The artery's pressure creates a slight pinch. Third, the ureter-vesical junction, where the ureter enters the bladder through a slanted, valve-like opening, which is narrow to prevent urine backflow. These constrictions are why kidney stones often lodge here, potentially causing pain or swelling like hydronephrosis. Want me to focus on what happens during blockages or how these points are clinically relevant?
I want to ask about the renal and ureteric calculi. What is this? Loin to groin referred pain.
All right, let's talk renal and ureter calculi, or kidney stones, for the podcast. These are hard deposits, often calcium, uric acid, or other minerals, that form in the kidneys, renal calculi, or get stuck in the ureter, ureteric calculi. They cause intense loin to groin pain when they block urine flow, stretching the renal pelvis or ureter, especially at constriction points like the ureter-pelvic junction, iliac artery crossing, or ureter-vesical junction. The pain radiates from the flank to the lower abdomen or groin because of shared nerve pathways. Small stones may pass naturally, but larger ones can cause hydronephrosis or infections, needing intervention. Want me to cover causes, treatments, or why the pain feels so specific?
That's all good. Let's talk about arterial supply of the kidney. So we have 5 segmental arteries, we have arcuate arteries, we have interlobular arteries. Explain me these arteries.
kidney's arterial supply for the podcast. The renal artery, branching from the aorta, enters the kidney and splits into 5 segmental arteries, each supplying a distinct kidney region, like apical, upper, middle, lower, and posterior. These feed into interlobar arteries, which travel between the medullary pyramids. At the cortex medulla junction, interlobar arteries become arcuate arteries, curving along the base of the pyramids. Arcuate arteries then send off interlobular arteries, radiating into the cortex, which supply the afferent arterioles of the glomeruli for filtration. It's a tiered system ensuring even blood distribution for kidney function. Want me to connect this to venous drainage or clinical issues like renal artery stenosis?
Tell me what each of these arteries supplies.
Here's the quick rundown for the podcast on what each kidney artery supplies. The renal artery splits into 5 segmental arteries, each feeding a specific kidney chunk: apical, top, upper front, middle, mid-front, lower, bottom, and posterior, back. Interlobar arteries, branching from segmentals, supply blood to the areas between medullary pyramids. Arcuate arteries, off the interlobars, deliver blood to the cortex medulla junction, feeding the boundary of pyramids and cortex. Interlobular arteries, from arcuates, spread into the cortex, supplying the glomeruli via afferent arterioles for filtration. Each level targets a distinct kidney zone for efficient filtering. Want more on their role in kidney function?
Yeah, what about the suprarenal, the gonadal, and the renal?
All right, let's clarify the arterial supply for the suprarenal glands, gonadal arteries, and kidneys for the podcast. The suprarenal adrenal glands get blood from 3 sources: superior suprarenal arteries, from the inferior phrenic artery, middle suprarenal arteries directly from the aorta, and inferior suprarenal arteries from the renal artery. These feed the adrenal cortex and medulla for hormone production. The gonadal arteries, testicular in males, ovarian in females, arise from the aorta, just below the renal arteries, supplying the testes or ovaries for reproductive function. The renal artery, also off the aorta, supplies the kidney, splitting into 5 segmental arteries: apical, upper, middle, lower, posterior, which feed interlobar, arcuate, and interlobular arteries to deliver blood to the glomeruli for filtration. Each artery targets its organ-specific needs: hormones, reproduction, or filtration. Want me to dive into their venous drainage or clinical relevance?
I'm gonna put a pause here. We'll be right back.